Hello everyone, today we would like to review about the tachycardia management. How to identify tachycardia? First thing first, we look for the heart rate. Tachycardia is a condition when the heart rate is more than 100 beats per minute. In ACLS, we look and treat the patient with tachycardia when the heart rate is more than 150 beats per minute. Next, why is patient tachycardia? Try to find the causes with tachycardia and treat the possible causes by airway breathing circulation approach. Firstly, we secure the airway, assist with respiration as needed. Administer oxygen if hypoxic. Maintain the oxygen saturation more than 94%. Do cardiac monitoring, monitor the blood pressure and SpO2. Then, identify is it the patient stable or unstable. If the patient unstable with the persistent tachyarrhythmia that causing the hypotension, decreased loss of consciousness, shock, chest pain, straight away do synchronous cardioversion. Remember, unstable patient we do immediately synchronous cardioversion. Here, the synchronized cardioversion starting dose. If the QRS narrow and regular, cardio rate at 50 to 100 joule. If the QRS wide and regular, cardio rate at 100 joule. If the QRS narrow and irregular, cardio rate at 120 to 200 joule. If the QRS wide and irregular, turn off the synchronized mode and defibrillate immediately.
Stable tachycardia. Stable tachycardia can be divided into two, which are prolonged QRS complex and normal or narrow QRS complex. For management of prolonged QRS complex more than 0.12 seconds, for example in ventricular tachycardia, first we establish intravenous or intraosseous line to administer the medication. In this case, the adenosine is not given. Instead, the intravenous procainamide 20 to 50 mg, maximum dose of 70 mg per kg, or intravenous amiodarone 150 mg over 10 minutes are given, with the second dose can be given for any recurrent ventricular tachycardia. If no improvement, we can consider giving antiarrhythmic infusion depending on the drug we have chosen before, which are maintenance infusion of procainamide at 1 to 4 mg per minute, or we can give intravenous maintenance infusion of amiodarone at 1 mg per minute. Next is normal or narrow QRS complex. For example, in supraventricular tachycardia, we are considering performing the vagal maneuvers, and after establishing intravenous or intraosseous line, we can give intravenous adenosine 6 mg bolus, and if the patient doesn't convert, we can give a second bolus of 12 mg adenosine if needed.